Thank you, Kali, for kind introduction. Great to see Professor K.K. Verma and my namemate, Rajendra. Ladies and gentlemen, it gives me a great pleasure to be part of the 50th celebration of Indian Association of Pediatric Surgeons. And I would like to dedicate this talk to my guru, Dr. Ravi Kumar, who helped me when I didn't have any money. So empyema is the oldest disease in the world. Egyptians know about empyema, Indians knew about empyema. If empyema does not rupture, death will occur. Unfortunately, we are all going to die of empyema. That's what the COVID has shown us. So in the last epidemic in 1917, two top surgeons died. William Osler died, Dupuytren died, and we all didn't know why they died of empyema, but you will know in this talk. So when I talk about empyema, I'm talking about the most common disease. I'm not talking about a rare cloaca which is going to come after me. It's a very, very common disease and very poorly understood because we spend all our resources on investigating rare conditions but not common conditions. I'm talking purely about community-acquired empyema. I'm not going to talk about the rest of the case. So the incidence of empyema all over the Western world has increased. It will increase here as well. 2 to 8% of children hospitalized with bacterial pneumonia develop empyema. The incidence has doubled and tripled, especially under the age of 5. Post-COVID, the incidence has grown all over the world. Why? Is it related that the GPs have stopped using antibiotics? Is it because of pentavalent vaccine? Or is it because of the emergence of the new bug? When all the antibiotics, every patient who comes to see me or see any of you would have had 6 antibiotics. So that's caused the emergence of the new session. It's called invasive group A streptococcus. When we all started group A streptococcus, you gave penicillin, you became a miracle doctor. Now streptococcus keeps laughing at you. Some children develop empyema, not others, we don't know. Probably you have genetic predisposition, I don't know. So we have 3 stages, which all of you know, stage 1, stage 2, and stage 3. Most surgeons would see only in stage 2 and stage 3. So we actually know the pathophysiology of empyema after a long time. If only we can find a blockers to any of this, we can prevent stage 2 to develop stage 3. So that research is very limited. So the management of empyema hasn't changed in 20 years. It's 200 years. It's nothing new. You give appropriate antibiotics. The problem is we don't know what is appropriate antibiotic. Complete evacuation of pus, that's what the surgeons offer. And preserve and restoration of lung expansion. Do we need X-ray chest? Yes, we need X-ray chest, and that's all you need. A good surgeon with a good X-ray chest can diagnose. You don't need a lateral view. The only other investigation a surgeon would need is an ultrasound. You don't need a CT scan. CT scan produces irradiation, and most of us can diagnose empyema without a CT scan. So ultrasound shows localization. The guesstimate about the volume is usually wrong, but any surgeon who can percuss well will know how much fluid is there inside. That's all you need. Don't do an CT scan unless you are suspecting empyema due to underlying CPAM or a lung abscess. So when to intervene? Is it day 5 to day 7? Is it because of the respiratory distress? Is it because of rising inflammatory markers? Or the ultrasound volume? Failed fibrinolytics? Other reasons, time to theater, expertise? There is no clear-cut evidence. Every group writes their own recommendation. Your group, Indian group, has got written a correct recommendation. To be honest, they said use VATS. The American group has swung into the other side, into the fibrinolytics, and the British group says it's case-based. To assess the spectrum of empyema and understand the development of empyema, I started doing VATS in 2004. I've got a prospective database, and I've used my data. So once you show an interest in any particular disease, and you maintain your own database, you can be a scientist. You don't need other people to tell you what is best, what is bad. I've had 173 consecutive cases, which has gone up to 200 now. So this is only the data on the patients whom we have operated up to November 2023, where we have every information. I'm happy to share all the information, whatever information you guys want. So the management option is either ICD with fibrinolytics, for which you need to put the child to sleep to do a chest tube in Western world anyway. And fibrinolytics are very expensive. And when the fibrinolytic fail, you still have to be the surgeon. So you have to suit what suits your institution. VATS review, VATS is the easy option, which we can train any registrar to do. The Cochrane review showed that the VATS group had a decreased mean length of stay. 5 randomized controlled trials have been done. 2 suggested that length of stay in VATS is less. They have a recent meta-analysis from Melbourne, and which clearly shows that VATS has got a reduced length of stay. So our protocol is very simple. Any child who is referred to empyema goes to pediatric respiratory surgery unit, and then they do serial ultrasound and X-ray. They refer to us the moment they think it's an empyema, and then we take over. So we do one-shot treatment. So we put them to sleep. We put an art line. We use bronchoscope if needed, and then we do a video-assisted empyema decortication. We published our early results in 2009 and showed that early referral improves outcome. So let's see how we are faring now. So a child with respiratory distress, just before I came, she was referred to me. She's a 13-year-old girl who was referred from the local hospital with 4-day history of dyspnea. Previous influenza infection, she was taken to intensive care unit. She was on 5 liters of oxygen. She was having respiratory distress. From the referral hospital, she was airlifted. This was an X-ray at the presentation. We rarely ever have a CT scan, but the referral hospital had done already a CT scan. It shows necrotizing pneumonia with the empyema. So that's a classical. So we took her to the theater. We put an art line. We did a selective lung intubation. Any kid over the age of 9, you can do selective lung intubation. Otherwise, you will never get a lung intubation for you. So this is how you do it, very easy. With the modern endoscope, it is a trainee doing a selective lung intubation. You can easily identify the individual bronchus, and then if a pediatric surgeon is lucky to get a single lung, it's a pleasure. Otherwise, doing an empyema becomes much more difficult. So this is a patient whom you use X-ray. So one has to be very, very patient when you do an empyema. The best would be to use a step port and then use a sucker and then slowly debride, and then you will get your time, and then you will be able to put other 2 ports. So this is actually my registrar doing the procedure. We can train any registrar to do this procedure. The more you do it, the better they become. It's important for us to train the future generation, because when we become old, we'll get empyema and they will be able to do it on us. So she is on day 1. You can see day 6 she went home. And what did she grow? She grew group A streptococcus. Case 2, 9-year-old boy with a rare condition called Lennox-Gastaut syndrome. Again, 1 week of upper respiratory infection, diagnosed with pneumonia with empyema. So that's him on treatment. So they airlifted him. So you don't see much localization, but still he needed surgery. We took him to theater. We got an IV access. We drained 2.5 liters of pus. And in spite of that, he needed a decortication, because you can see he's got still layers and layers of pus stuck there, and we did the decortication. Again, first postoperative day, invasive group A streptococcus. Group A streptococcus is now emerging as the #1 organism, and if you don't go in early and treat, they can get multi-system organ failure and die. Unusually, you will get a lung abscess, which can be again easily dealt with the thoracoscopy, and you do it thoracoscopically. You can drain the empyema, you can put a chest tube. So if you look at my data, you can see that you have 173 cases. From 2015 onwards, you can see what happened was group A streptococcus became a problem all over the West. So 2015 it started, you can see the numbers go up, and then during COVID, the numbers stopped. It's because of the measures we used in COVID, the number of empyema stopped. The moment COVID got over, again went to 24, and this year is 25. The patient characteristics have not changed. You can see the male-female distribution, median age, all look the same. The aboriginal patients seem to have a higher incidence of empyema in our group, but again, it's not statistically significant. When you take this empyema into simple and complex, complex empyema is divided as one with a bronchopleural fistula, one with necrotizing pneumonia or a lung abscess. Is there a difference in the identifying? We are seeing more complex empyema since 2015, and it's probably due to group A streptococcus. If you look at the clinical presentation, again, simple and complex, we can't differentiate clinically. All of them have high-grade fever associated with cough and respiratory distress. One can't differentiate, but any child with a temperature more than 39 degrees with persistent respiratory distress, think of empyema. Preoperative investigation, almost all patients had a chest X-ray and ultrasound. We rarely did CT scan. So the mean number of days from VATS to the referral from the pediatric respiratory unit to the surgery was 1.4 days. You can see the localization was demonstrated in 85% of the patient. Peel was removed in 28%. The need for second operation is only 2.9%. Conversion to open happened only in 3 cases. I'll show you that. Where do you go from operating theater? You go to the ICU, stay there for 24 hours. Most of the time they can go home, go to the ward in a day or 2. Rarely they can go straight to the ward. So if you look at the mean duration of postoperative stay for simple empyema is 8.83 days. If you do fibrinolytics, it will be much, much longer. Mean ICU duration is 2.1, and the patients always get better, and you have organisms to grow. If you compare complicated with uncomplicated, we had uncomplicated 148, complicated 25, of which lung abscess associated with empyema and 16. Others were bronchopulmonary fistulas and necrotizing pneumonias. So the operative details, when you look at the 2 groups, again, there is a slightly increased conversion rate in a complicated empyema, but again, you can still do all complicated empyema once you get the skill. It is not that difficult. Conversion is very rarely needed. Nowadays, I don't convert at all. If you look at the microbiology pattern, before 2015, Staphylococcus used to be the number 1. From 2015, the organisms started coming, which is a group A streptococcus. So this one gives a complete distribution of streptococcus from 2017 onwards. During the COVID, there has been a drop. Whereas necrotizing pneumonia, which is unusual, which is a severe complication of CAP, again, more commonly seen with streptococcus pneumonia. So the Australia experienced increase in the incidence of eye gas among the children from 2022. It was first reported in UK in 2015, and then US, and then it came to Australia. It won't be long before it will come to other countries. Strep infection affects 750 million people all over the world and 500,000 globally every year. So you can see the strep pyogenes is number 1 in our area of health, where you can see the distribution. And what caused this is the virulence factor called M protein. So this is a particular group of streptococcus with increased M protein. And this M protein strain started in UK, it's called M1 UK, started in 2010 there, and then by 2015, it spread all over the world. This is a M1 UK pattern in our hospital. So in conclusion, the era of increased incidence of severity of childhood empyema and worsening severity of underlying pneumonia, VATS continues to be a successful option. If you are, any surgeon can do, a pediatric surgeon can do VATS. So in one go, you will be able to do outline, IV access, intubation, chest tube, clear whole thing, and the patient goes home in day 7. Like morning Singh was saying, whether you do single shot treatment or multi-shot treatment, to the patient always prefers a single shot treatment. If you are the mother or the father, you want, many times in pediatric surgery, people don't worry about evidence. They worry about their child. They want the child to go home safely. And in your hands, almost all patients with empyema think you are actually God, because no antibiotics actually work now. So the algorithm for surgical empyema continue to be, if you have respiratory distress, good, then do an ultrasound, chest tube, if it's really, really bad. Otherwise, you do everything in operating theater. In one go, you can fix everything. You can train your trainees so that they will be also able to do it in 20 years' time. Thank you.
Nice talk, Rajendra Kumar. Two questions. What is your approach for necrotizing pneumonia with empyema, resulting into, say, bronchopleural fistula, bad lung when you put in the scope?
It's a beautiful question, Rajendra. See, necrotizing pneumonia, you will recognize the kid will be out of proportionally shocked, okay? And you would know this is what's going on, like only 48 hours, and you'll be out of proportionally shocked. And then when you put, if you do a CT, you can easily recognize it, but I don't recommend that. You will go in, but most likely, like, you will get a bronchopleural fistula. And I feel once you see in the lung necrosis, you put a tube, I tell them usually it takes 2 weeks. I don't actually do the flap procedure, which you probably are going to allude to. I don't do any of those procedures. All of them still go home. I don't think you need to do anything to these lungs. They are so friable, if you don't touch them, they always get better. Do you do flap procedure? Yes, I know that. I know, but I am a non-operative surgeon when it comes to empyema, because in my hands, if I go and play with that lung, it will come into my hand. I don't want to do that. I don't know how many of you guys, you know what he's talking about. You can tell them. So what he's talking about is, if there is a persistent bronchopleural fistula, either sit tight or send them home with the chest tube and then take the chest tube in 3 weeks. Or if you put a flap and cover the area, then you can send them earlier. So group in Birmingham is a big advocate of a flap procedure. I think he belongs to that group.
Another question, in your...
Sorry? Yeah, it's a very good question. How do you culture? See, the reason I am able to grow all them, initially first 10 years, I was trained in pediatrics in this country, and initially anybody whom you don't grow organism, we call it TB. It's the biggest lie people told me. Because first for 10 years, I never grew any organism. So I got Hema, who is a top microbiologist, to get interested. So we take aerobic culture, anaerobic culture. The most important thing, there is a thing called 16S. You can do that 16S, and then that will pick the streptococcus straight away. You need a microbiology friend, like a pathology friend, if you want to get a good outcome. Sorry.
Yeah, Dr. Rajendra Kumar, I'm Sanjay Rao, I'm from Bangalore. Thank you. I always thought that bad empyema was a tropical country phenomenon. Obviously, it doesn't look like that. We always thought it was predominantly nutrition and malnutrition associated. Again, no. It doesn't seem like that.
No, I want to stop you there for a sec. It's because when tropics, because the population is high, during COVID, you have seen that when the kids don't meet with each other, they don't get immunity. So my registrar who came from Sri Lanka said, I've never done so much empyema in Sri Lanka, what's happening? I said, because they're all together closely, therefore you get actually mild infection and antibodies. Whereas we guys don't do that, and you get diarrhea when you come here, the same thing.
So do you get patients referred who have had, pleural installation of, fibrinolytics? And when you operate on them, do they behave differently than you would operate on patients who did not have it?
It's a completely different ballgame. It's very difficult, but if you take pus and you pour stuff into the pus, you can fix any pus. But then when you go in, you can't get a plane. And since you haven't done an open thoracotomy for empyema for a long time, you feel like a defeat. It's like going into appendicitis after 7 days. You know the feeling. You know you can do it, but it's annoying. So I don't want to waste anybody's time. I just go in and fix it. I'm sorry, Americans think that fibrinolytics would work better. I can show you the data. This is what they would do. You do what is good in your hands. That's what Singh told this morning. Is that right? In hypospadias, you do what is good in your hands. Doesn't matter. I don't want another country to tell me what I should do. In India, if you don't interfere, the problem is our patients, you can see, obesity is the reason. Here, undernutrition is the reason.
Yeah. So, any other question? Yeah.
Great talk, sir. I'm Dr. Vineet from Kochi, Kerala.
Are you a trainee?
Pardon, sir?
Are you a trainee?
No, I'm a consultant, sir.
I said, during your training, how many VATs did you do?
I've done close to about 15 to 20 watts, sir.
See, the experience, we have to give the younger generation more experience.
Yes.
This is an easy case to learn. It's like appendix. I'm not saying that we should operate on everybody, but I'm just saying.
So I was in Australia for about 3 years. I was in Adelaide. They were doing the ICD insertion and alteplase. They had good results at that point in time. We rarely took children to theatre. I've come back, been in Cochin for the last 3 years. I've been actually practicing a lot of. I think I think that maybe the difference is I think it depends on the type of fibrinolytic. I think that's very, very important is what I feel. I feel that when I was training in PGI Chandigarh, they used to use streptokinase and we had to do a lot of thoracotomies. As you rightly said, the peel's very, very thick. But I think when you use alteplase, I think there is a significant difference because I think there's not much of tissue reaction compared to the streptokinase or the urokinase, which does.
I think, sorry guys, I think we'll have to make a stop there. Point well made. And I think you can discuss it over coffee or tea. Thank you very
Thank
much,
you, everyone.
Raj. Thank you.